Kia ora koutou, and welcome to tonight's Goodfellow Unit Webinar on the impact of diabetes on sexual function. My name is Dr. Courtney White, and tonight we'll hear from Dr. Giovanni Losco, an adult and pediatric urologist with extensive experience in reconstructive urology and urethroplasty, amongst many others. After being awarded a traveling fellowship in the USA, he operated with world-leading surgeons in erectile dysfunction. He now holds a number of leadership positions, including the Clinical Director of Urology in Canterbury. This webinar is sponsored by an educational grant by Boston Scientific. The content was developed independently by the Goodfellow Unit and our expert speaker. So I'll now hand over to Giovanni. Thank you.
Thank you, Courtney. Tēnā koutou katoa. Thank you very much for having me. So this is a talk about erectile dysfunction with a little bit of a flavour of diabetes, but I'm really going to talk about erectile dysfunction fairly generally, and also speak specifically around some of the impacts that prostate cancer treatments have on erectile function, because that's one of the most common reasons that we see it in my practice anyway as a urologist. So the aims of tonight is to talk about the causes of erectile dysfunction, specifically the effects that diabetes has on it, how prostate cancer treatments can cause it. We'll talk a bit about how common it is, and then the most key thing, or hopefully the most interesting thing, is talking about the treatment options, some of the different things we can do to try and help men with ED. So broadly speaking, the way that I always explain this to patients is that the same thing that causes heart attacks and strokes is the same disease which causes erectile dysfunction. So the arteries to the penis are some of the smallest and narrowest in the body. And that process of atherosclerosis, that plaque buildup inside the arteries, is the same issue that affects arteries to the penis. So all the same kind of risk factors. So there'll be a slide shortly that explains this, but it's all about blood getting into the penis. That's one of the key things you need to get a good erection. And if your arteries are coming narrow and clogged, then that's just not going to happen. So often erectile dysfunction is one of the very first manifestations of cardiovascular disease or vascular disease. So this slide sort of outlines the most common risk factors for erectile dysfunction, and the same things that are risk factors for cardiovascular disease. So high cholesterol, a high salt diet, hypertension, not having a good diet, not having good healthy balance of exercise in your lifestyle. So trying to maintain all these, and these are risk factors which you will be really familiar with in primary care that you're managing with your patients all the time. But these are really the same risk factors that we're dealing with in erectile dysfunction. So the first thing that I always talk about when men come into my office or room about erectile dysfunction is looking at generally their cardiovascular risk profile, making sure that their blood pressure, their cholesterol level is being monitored, and their sugars are being monitored for diabetes. So a little bit of anatomy. If we branch out to anatomy for a moment here, we've got a cross-section of the penis, a little bit of a sad face, I always think. So you've got the two corporal bodies, one on each side, and then the corpus spongiosum, which is the tube that carries the urethra. So the urethra is in the middle there. Corpus cavernosum are the really rigid erectile bodies that are surrounded by this layer called Buck's fascia, which is a really tough, thick fascia. And that's when this fills up with blood. Those are the two rigid rods that are on the side of the penis that cause erection. This is some other stuff here around the blood supply. You've got the deep dorsal vein, the superficial dorsal vein, and then those dorsal penile arteries. And then this cross-section on the bottom right of your screen just shows some of the complexity about how all that layering works. And one of the things I want you to look at specifically are these veins here that wrap around the outside of the corporal body. And why that's relevant is that there are really two things going on in an erection. The first thing, as I said before, is blood needs to get into the penis. But the second thing is blood needs to not get out of the penis. So it's got to go in, and it's got to kind of stay there. And one of the really clever things around the anatomy is that as those corporal bodies expand and get full and engorged with blood, that causes compression of these veins, which are on the outside, and that then stops the blood escaping. So hence you get an erection. So this is in a little bit more detail. So the corpus cavernosum becomes erect, and the very first thing is that sexual stimulation, which triggers those neurotransmitters from the ends of the nerves that causes relaxation of the smooth muscles in the arterioles. And those arterioles therefore dilate and increase blood flow. Important, the concept of sexual stimulation, because all of the treatments, Viagra, Cialis, etc., they still rely on sexual stimulation because you still need that to actually trigger the release of the neurotransmitters. As I said before, that then causes blood to be trapped because those sinusoids become compressed around those venular plexuses on the outside of the penis, and therefore you get a decrease in blood exiting the penis. So that tunica, that's the covering of the corpus cavernosum, becomes really stretched. The pressure becomes really high, 100 millimeters of mercury. So if you think about what your mean arterial pressure is in the resting state, this is higher than your mean arterial pressure, quite significantly higher. And then the other thing is the ischio-cavernous muscle, which is that muscle which sits just underneath the crura of the penis, and that contracts and causes increased pressure. So that's what's going on in the corpus cavernosum, or the corporal bodies, which are the really key things that cause erection. The corpus spongiosum is that softer tube that surrounds the urethra. So that has a similar physiology in terms of the arterial inflow with the dilation of the arterioles, but the corpus spongiosum is a lot thinner, and therefore the venous occlusion is less of a major factor. And therefore, in a normal male erection, you'll find the corpus spongiosum on the underside of the penis is always quite a lot softer than the corpus cavernosa on each side of the penis. So in summary, you've got those three elements: relaxation of the sinusoids, dilation of the arteries, and the venous compression. So those are the three things you need to create an erection. And later on in the talk, when we start to talk about some of the treatment options, that will become relevant because each of those treatment options works on one or more of those elements. Nitrous oxide is the main chemical mediator of erection. That's the neurotransmitter, which is actually being released from the cavernosal nerve fibers. It's synthesized by nitrous oxide synthase in the axons, and the expression of that enzyme, nitrous oxide synthase, is regulated by dihydrotestosterone. So DHT, which is the active form of testosterone. Testosterone, obviously the male hormone made in the testicles, that is transformed into dihydrotestosterone by the enzyme 5-alpha reductase. And the DHT actually regulates the expression of nitrous oxide synthase. So that's just telling you how testosterone plays a part in all of this. You need testosterone. If anyone thought that 5-alpha reductase rang a bell when I mentioned it earlier, that's because that is what finasteride inhibits. So when we use finasteride for male pattern hair loss or finasteride for BPH, that's exactly what it does. It stops the conversion of testosterone to dihydrotestosterone. And really, this just summarizes what I'm saying. So if you don't have as much testosterone, such as a man with hypogonadism, that's going to cause a decrease in the nitrous oxide synthase, and that's going to cause essentially a decrease in the ability to achieve erections because you're not getting those dilations of the arterioles. The other thing that testosterone does as another primary effect is it maintains smooth muscle. So you need that to have maintenance of smooth muscle and also collagen in the body. So in terms of epidemiology of erectile dysfunction, we're talking about half of men over the age of 70 will describe a degree of erectile dysfunction. If you compare that to testosterone, only 0.5% of men have got an abnormally low testosterone. However, around 12% of patients with erectile dysfunction are hypogonadal or testosterone deficient. So what that means is, erectile dysfunction is clearly one of the symptoms or manifestations of hypogonadism. It is not common, but it's not uncommon either. 12% is a reasonable proportion of men that have hypogonadism. And for that reason, whenever I see men with erectile dysfunction, I do tend to check their testosterone level because it's a really relatively simple diagnosis that you could make, which is potentially treatable with testosterone replacement. And I'm not going to go into that, but it's just to say that is a reasonable diagnosis to exclude because it is relatively treatable. So now a little bit about diabetes, and it's all about the macrovascular impacts of diabetes that really cause erectile dysfunction. So I must admit, as a urologist, my knowledge of diabetes is not at the very tip of my tongue like I expect it may be with many of you, but the factors that are involved in how diabetes causes damage to vessels are really here on the slide. So that causes endothelial dysfunction, again, through those mediators around nitrous oxide. It causes direct inflammation, tumor necrosis factor, interleukin-6, etc. So there's that inflammatory effect on the vessel wall. And then finally, there's that fibrosis and remodeling that you get, which is the same reason that diabetes increases your risk of heart attacks and strokes, and ultimately that same process that we all know as atherosclerosis. So that poor glycemic control is triggering all of these factors, which are directly affecting the blood supply to the penis. I'm going to spend a little bit of time now just talking about how prostate cancer treatment influences erectile function, because many of our treatments, unfortunately, cause erections to be worse. And some of those causes are quite unique or quite specific to the treatments for prostate cancer. So the radical prostatectomy, which is a standard operation for surgical removal of the prostate in men with intermediate risk or high-risk prostate cancer, commonly causes injury or damage to the nerves that supply erections. So this little graphic here shows you the bladder in gold, prostate sitting below it, and then the urethra or the urethral sphincter sitting just below that. And in blue are marked the nerves or the neurovascular bundle. And this is intended to demonstrate that these nerves are really hugging extremely close to the prostate. And in real life, that other slide that's coming in a second, they are really intimately associated with the prostate and not actually visible to the naked eye. You can't see those nerves. So when the urologist is removing the prostate, making this cut here, one end at the urethral sphincter and the other end of the bladder, those nerves, those little blue bits, little fingers that are hugging the prostate, they have actually been, deliberately removed. So in some men that need a slightly wider excision to make sure their cancer is cured or completely removed, their nerves will be sacrificed. We call that a non-nerve sparing operation. In other men, we can attempt to do a nerve sparing radical prostatectomy. And in that case, we attempt to leave those nerves behind, but that can be very difficult. And this is really intended to demonstrate that. So this picture here is a picture at a robotic operation. So there's a telescope looking inside someone's abdominal cavity. On the left of the screen, labeled prostate, this whole structure here is the prostate. On the right of the screen, this is the pubic bone. And then these little nerves here are intimately associated with the prostate. And the artist has very kindly colored them for us. But of course, in real life, that's not the reality. You don't actually see them at all. You just know that they're there, but you can't actually see them. So you have to sort of very carefully tease these layers away from the side of the prostate, and in doing so, hope that you preserve them. So it comes as no surprise that even if you manage to sort of successfully spare the nerves, even in that case, your outcomes are around 1/3 of men will have normal erections, 1/3 will not get erections at all, and the other third will get erections, but they'll need some help in terms of some of the treatments that we'll discuss shortly. Radiation treatment also causes problems with erections, and the reason is still based on that same anatomy. So the radiation waves are being targeted at the prostate, and modern radiation is much better than it used to be at really targeting those radiation rays at the prostate. But again, you can imagine those nerves are intimately close to the prostate. So naturally, they're going to get a bit of a hit from the radiation, and that can cause some damage and therefore erectile dysfunction. Erection problems do tend to be less after radiation compared with surgery, but they do still occur. Hormone treatments in men with more advanced prostate cancer, we often treat them with medication which lowers the level of testosterone in the body. The brand that was really well known in New Zealand until recently, Zoladex, or the generic name Goodfellow, is what's commonly used. So this is an LH agonist, and that has the effect of suppressing the level of testosterone. It's a slightly tricky one to get your head around because it's called an agonist. What it actually does is it initially causes a real surge in testosterone, but then those receptors get completely saturated, which has the effect of then causing a real depletion in testosterone. And these little figures here, we all know what it looks like when you're hypogonadal, and one of the effects obviously is erectile dysfunction. But not everyone is prone to erectile dysfunction following prostate cancer treatment. It depends, of course, on what your erections were like beforehand. If your erections beforehand were not good, they're certainly not going to get better, and they are more likely to get worse. So your pre-treatment level of erectile function is important. Type of treatment, as I mentioned, radiation does tend to cause less of a problem than surgery. And your family history is of relevance, particularly if there's a family history of cardiovascular disease. So now we're going to talk about some of the treatment options for men with ED. So there's this ladder or hierarchy of options, starting with medications. There's vacuum devices, which are a non-medical alternative. There are injectable agents, and there are implants or surgical procedures to create erections. There's a whole lot of drugs in terms of different branding available in New Zealand. Viagra, obviously very well known, the original PDE5 inhibitor, phosphodiesterase type 5 inhibitor, the generic name is sildenafil, and there are a number of cheaper versions available now than Viagra, which are all sildenafil. Tadalafil, which is marketed as Cialis, and vardenafil, which is marketed as Levitra. The couple of things to know about these different medications is that they're all PDE5 inhibitors, but they all do work, slightly differently. So just because a patient hasn't responded to well to one doesn't mean they won't respond well to the other one. Viagra comes in 25, 50, and 100 milligram tablets. My practice is sildenafil. My practice is to prescribe the 100 milligrams, to tell the patient to cut it into quarters, because that just tends to be a little bit more economic. I believe that the cheaper generic brands of sildenafil now are available for just $1 or a couple of dollars a tablet. It is worthwhile telling your patients to shop around because different pharmacies will charge different prices. So it is worth shopping around. Cialis comes as both a 20 milligram tablet and also a 5 milligram tablet. The intent of the 5 milligram tablet is that you take it every day. So it's a regular background level of Cialis in the body. Whereas the 20 milligram and the other drugs are really intended to be used on a PRN or as required basis. And they're the instructions that men need to have when taking these medications. So there does need to be sexual stimulation. As I said earlier, not just a matter of popping a tablet and getting an erection. You need that sexual stimulation to actually release the nitrous oxide from the end of the nerves that triggers that whole process. Doesn't work so well after a fatty meal. This is particularly the case with sildenafil. It's not as well absorbed, and you do need to take it a decent amount of time before sex. This differs between the different drugs, but for sildenafil, it really needs to be ideally 60 minutes before sex. Before giving up, before deciding that this drug is no good and it's not working, I always recommend that men try it on at least 6 occasions and at the highest dose. So for sildenafil, that'll be 100 milligrams, taking it at least 6 times. And if it's no good, don't abandon the drugs, but try a different brand such as Cialis or Levitra. These drugs do all have a range of similar side effects just based on their drug class. Hot flushes are really common. A headache, some men complain of muscle ache and backache. Some of the really curious ones are a blurred vision or blue tinge to vision. That's a recognized side effect of sildenafil. Stuffy nose or runny nose. One of the most bothersome side effects I find that men complain of is the backache and the flushing. That can be quite a difficult thing to deal with and maybe enough to make them stop it. The other thing that I always advise patients is that you go online, it seems like you can get some good deals, which may be too good to be true, and they probably are. We all know this, but patients don't always necessarily know this. It might say on the internet that it's got sildenafil in it, but you don't really know, and it's just not worth it. So I always advise people to shop around at some of the reputable, or our own reputable New Zealand-based pharmacies. So vacuum devices are a non-medical option. They don't involve any kind of drugs, and there's a whole range of different devices. You can buy them on the internet. You can buy them in shops. Typically, these are available in adult shops or adult sex stores. They can have quite an eye-opening range available, actually. But the basic principle is that you've got this plastic cylinder which fits around the end of the penis. There's a pump that pumps out the air, so the penis is sucked up, such as in that diagram. And then you put some kind of constricting ring, a rubber ring or so forth at the base of the penis that then maintains the erection. This requires a little bit of fiddling around, a little bit of faffing around, and some men do find that difficult. But on the other hand, some men like the fact that it doesn't involve any sort of medicalization or drugs. Your next option in the ladder are the injections. So the simplest injection available in New Zealand is the one marketed by Pfizer called Cavaject. And the reason that's very simple, a bit like an insulin pen, it kind of dials it up. It's pretty easy. It's pre-packaged. It's got a needle attached. There's a little dial in the window that you dial up the dose, and then you just stick it into the inside of your penis or into the side of the penis. So again, there's that cross-section of the penis here, similar to that diagram that we saw earlier. The idea is to get that needle into the corpus cavernosum, so into the lateral side of the penis. You don't want to go for the underside where the urethra is. Quite a short needle, so you can plunge the full needle right up to the hilt into the side of the penis and then inject that. Cavaject comes in both a 10 microgram syringe and also a 20 microgram syringe. Generally would start men on a 10 microgram syringe, usually at the 10 micrograms, the full dose. This little demonstration suggests 7.5, but I generally wouldn't bother with that, just start with the 10 micrograms. And if that doesn't work, then they can move on to the 20 microgram syringe, in which case they may go with a 15 microgram dose and finally a 20 microgram dose. And the problem with Cavaject is it is more expensive because of its prepackaged design. There are some places around the country, some urologists, and also I believe a compounding pharmacy in Auckland that will make up their own syringe of alprostadil. So I didn't mention that this drug is alprostadil, so prostaglandin. There used to be mixtures available called Bimix and Trimix. They're much less easy to get hold of. I'm not personally aware if you can get hold of those in New Zealand anymore, but that used to be in the days of the compounding pharmacies were really commonplace, quite easy to get hold of. The risks of injectables priapism, so that's the erection that's so good that it doesn't go away, which, you know, is quite a bad problem. It may not sound so to a man that hasn't had an erection in a long time, and pain. So some men do find the injection process painful, and sometimes the strength or rigidity of the erection can be painful as well. So that finally brings me to the top shelf. So I kind of explained to men that this is a little bit like the top shelf at the bar. It's got the best stuff, but it's also the most expensive. So generally men would work through these things in a stepwise manner. There's a few different brands available. Essentially, they do the same kind of thing. So the Coloplast Titan and the AMS 700, which is distributed by Boston Scientific. So this is an example of what the Coloplast Titan looks like. There's these two cylinders. One goes into each corporal body. So you can see on this diagram here, there's that plastic cylinder going into each corporal body. There's a reservoir of fluid, which is buried inside the abdomen. And there's this button or pump that sits inside the scrotum, just in front of the testicle, like a small third testicle. So to do this operation can be done a couple of ways. I would do that with a small incision just above the penis. Some surgeons will do it with an incision in the scrotum and also another incision in the lower part of the tummy. But there's those three components, one being the two cylinders, then the reservoir, and then the pump. And this is just another little example of how that's going to work at rest. So at rest, those cylinders are empty of fluid. Then when you want to get an erection, you're going to pump the pump. I've got a little video coming up shortly, and that's going to cause the cylinders to fill with fluid. Those cylinders are really quite rigid. The reservoir relatively empties of fluid because that fluid has entered the cylinders, and that causes an erection. So here's a little video which seems to be working. So this chap here is going to pump his little pump in the scrotum there between his thumb and his index finger. And that's going to cause the cylinders in the penis to fill with fluid and give him an erection. And then when he's done what he wants to do, he's then going to reach in, and there's another little button there that he's just going to press. And with his other hand, just gently squeeze the penis. That causes the fluid to empty out, and his erection's gone away. That's obviously all buried inside the body, so no one can see. The AMS 700, which is marketed and distributed by Boston Scientific, really is the original device. It's been around for a long time, 30, 40 years, I think. So they really came up with the original concept. It's still around, the more commonly used device in New Zealand, I believe. The reason it's orange is that it's impregnated with an antibiotic called rifampicin, and that is done to reduce the risk of infection after the implant. So that's why it has that orange color, but very much the same concept. The other thing I should say is that at the time of surgery, an enormous box arrives with every size cylinder that you could possibly imagine. And then during the surgery, we measure up the man's penis internally, and we make sure we place the cylinder of the correct size. So there are lots and lots of different sizes available. Like any operation, particularly prosthetic surgery, there are risks, and one of those risks is infection. The device is made of plastic. There are lots and lots of things we do at surgery to reduce the risk of a serious infection. But unfortunately, in those rare cases where infection does occur, that's very serious, and the device usually needs to be explanted or removed, which is obviously a really devastating outcome for a man that's gone through with this operation. In the fullness of time, we may be able to place another device once the infection's settled. The other thing I always explain to men is that this is a mechanical device, so like your car, it's prone to breakdowns. If it has a breakdown, that means it needs a service. And if it needs a service, that generally needs another operation. So common things that can go wrong would be some fluid leakage from the device, so the reservoir loses fluid, or a faulty valve in the pump in the scrotum, or sometimes a connection just comes apart. That's not very common, but the risk of any mechanical device is that obviously it is occasionally prone to some mechanical failure. I thought I'd talk just briefly around accessing care for erectile dysfunction in New Zealand, and particularly with a view to ACC. As most of you will know, there is really no funding for erectile dysfunction currently through any pathway, and all treatments, be they the oral PDE5 inhibitors all the way through to surgery, are generally self-funded by patients. So no available public funding. There is very limited funding through ACC through the treatment injury pathway. We're recently starting to look at whether we might be able to try and convince ACC to expand that a little bit. There are very rare cases only where ACC has approved men for treatment injury after radical prostatectomy. We have had some success with men that have had problems after colorectal surgery, so like an anterior resection for a bowel cancer, and then they've been left without erections. ACC have approved some of those in the past. We do commonly expect approval for men that have had spinal injuries or other major neurological injury or trauma. Generally, they would be accepted by ACC. So probably, in fact, around half of all of the penile prostheses that we do, or in my own practice, would probably be funded by ACC. And the rest of them are generally, those costs are at the expense of the patient or family. In terms of ACC treatment injury, anyone can make a claim. That can be done in primary care, it can be done in a clinic, it can be done by RMOs in the hospital. ACC does tend to take its time to come to decisions. I'm sure you're all well aware of that. 6 to 8 weeks is probably a minimum. Sometimes we're surprised and it can be done much quicker, but more often than not, it's the other way and we're still waiting, 3 months down the track. Having said that, once you do have ACC approval, once you've got them on your side, then that claim is approved for life. So should they come back with some of those dreaded complications that I mentioned before, device leak, loss of fluid, etc., then ACC will always fund any other treatment required. So there's no excess for ACC procedures, and once they have that claim approved, it never goes away. It also covers patients for other things too, like the costs of travelling. I have quite a few men that come from all over the South Island, so ACC will at least assist in some of those costs of transport and travel. So if you are putting an ACC treatment injury claim in for erectile dysfunction, there's a few buzzwords that you really need to try and include in your application. The ideal way to get a claim through ACC is to have it get entirely assessed by the non-clinical people that assess the claim. So if you get more questions asked and it gets escalated to other people, that's when you start running into trouble. So if you can try and include those key buzzwords in your initial application, the people looking out for those key buzzwords are more likely to approve it. And one of the principles around the treatment injury is that there has to be a physical injury. So erectile dysfunction, for example, that's a symptom. That's not an injury. So you've got to state the injury really clearly. And I would say that would be damage to nerves. You just say the nerves have been damaged at the time of surgery for prostate cancer. A couple of things you're going to look out for. If the man is documented to have erectile dysfunction before their prostate cancer treatment, that's going to be a bit tricky to try and get that one across the line. So if you can document that they had good erections before treatment. The other thing, potentially a little bit of caution, is if they've also had radiation treatment, they might say, well, look, actually, you've had surgery, you've had radiation, probably having erectile dysfunction is a more likely consequence and wouldn't really form part of their definition. Boston Scientific are doing a little bit of work at the moment with ACC and trying to build a little bit of a case here that would suggest if you meet these 3 criteria, which is you had good erections before your surgery, you were less than 65 years of age, and your surgery was nerve sparing, that really you should end up with good erections. And I think most urologists would say that in this group of men, they really should end up with good erections. So if they don't, that may constitute a treatment injury. In a little case, there's not a whole lot to it, but Mr. P is a chap with diabetes. He's 65 years old. He's had type 2 diabetes since the age of 50. And he managed that for many years with diet and lifestyle, and that was working very successfully, or for the first 5 years or so. And then for the last 10 years, he's been placed on metformin. He's got pretty good glycemic control. His HbA1c is 48. So he and his GP are reasonably happy with that. And other than his diabetes, he's got pretty good health. He's not had any other major events in his life, no sort of known cardiovascular disease. But he presents with erectile dysfunction. It's a bit I missed off that slide, actually. So he presents with erectile dysfunction. He's married. He has a wife, and when they attempt to have sexual intercourse, he has an erection which he describes as really just being sort of semi-erect. I recently came across a grading system for erections, which I have to admit I hadn't come across before, but it was quite a good one actually. It made me chuckle, where the softest erection is described as a marshmallow. The next step up is a peeled banana, so the inside of the banana. The next step up is the unpeeled banana, and then the best erection is a cucumber. So that's a nice way perhaps of explaining to men if they're trying to describe to you what their erections are like. So this man's erection was really what he called a peeled banana. So it was a bit of an erection, but not really that great. And he wasn't able to penetrate his wife successfully with that. So if you saw this man in your clinic, the very first thing that you should do is think about all those risk factors that I mentioned earlier. Now, he's got diabetes, he's on metformin. It's highly likely that you're already on top of this stuff because he will be coming to you for regular checkups anyway. But it's just an opportunity to make sure that, yep, his blood pressure's okay, his cholesterol's okay, yeah, the HbA1c is good, we're okay with sugar control. Talk about diet and lifestyle. Of course, for men that do have problems in those areas, fixing those in and of itself isn't going to improve the erectile dysfunction, but hopefully it may stop it from getting worse or may slow its progress in any case. You might also be doing them some other favors because, as I said, sometimes erectile dysfunction can be the first manifestation of cardiovascular disease. So by treating those risk factors now, you may also delay or prevent heart attacks and strokes in the future. So my ladder of treatment options typically always talk about oral PDE5 inhibitors in the first instance, typically with sildenafil because that's the cheapest. We'll talk about that. I may or may not mention vacuum pumps in that first consultation. You often get a little bit of a feel from the patient whether that's something they would like to do. People often perceive the medications to be relatively simple and easy, and the cost has come down quite a lot. The next is injectable therapy if they haven't had good response from both the tablets and the pumps. Should have mentioned earlier that injectable therapy, there's often a few people in your town, be they urologists or nurse specialists. There are some GPs I know around the country that set themselves up around injectable therapy. They can offer the patient a service whereby there's some education into how to use the injections. I don't think it's very common for GPs to simply prescribe an erection to a patient. Often they are referred on to a service that could prescribe the erection and give the patient an education session around how to use it. It's not to say that you can't, but it's probably not done so commonly. And then finally, look, if they're not having good erections with all of those other options and cost allows, some patients are lucky enough to have very old insurance policies where penile prosthesis surgery may be covered. Unfortunately, most modern or insurance policies have been taken over, say, the last 10 or 15 years tend to exclude erectile dysfunction as a policy exclusion. Some men who had policies for a long time will get this covered, but most men are having to self-fund this. I should say the cost of the device itself, that's just the device itself, is somewhere between $15,000 and $20,000. So It's expensive. And on top of that is obviously the cost of the surgery, the surgeon, the anaesthetist, the hospital, and so forth. So it's an expensive operation. So this is what we covered tonight. We'll talk about the causes of ED, focusing on cardiovascular risk factors, touched on how diabetes specifically affects erectile function, talked quite a bit on how prostate cancer treatments affect erectile dysfunction, as well as how common it is. And then we've reviewed all of those different treatment options. So that's the end of my sort of formal or didactic part of the presentation. So I'll bring Courtney back into play and we might have some questions.
Thank you. That was a really excellent, really clear overview. Thank you. A few questions coming in. For patients on finasteride, is there any reason they can't have sildenafil at the same time?
No, absolutely not. They can certainly have both. That's both finasteride and sildenafil. Yep, they work on quite different pathways. Sildenafil is a phosphodiesterase type 5 inhibitor. So that's got nothing to do with the testosterone pathway, whereas finasteride is a 5-alpha reductase inhibitor, so quite safe.
Thank you. The blue tinge that people can get with the sildenafil, I think you said, do we need to do anything with that, or will that just self-resolve and they don't take any more of it?
Yeah, look, that's a great question. Look, I think it's self-limiting. I don't believe it's a concerning sort of ophthalmological problem. I've only seen, I think, one man with it, and he found it very disconcerting and wanted to stop the medication, but I don't believe it causes any irreversible damage.
With the testosterone levels, who would you test? Sometimes we get requests just for men with fatigue, asking to check testosterone. Who would you check in terms of kind of age range or what they're coming in with?
No, I feel like I'm on the spot with that one because hypogonadism is another whole political hot topic, and there are some guidelines out there around who to test, around symptoms and age. So I don't want to put people wrong by just picking a number out of the air. Obviously, the symptoms of hypogonadism are very vague and non-specific, and that does make it quite challenging. But there are some guidelines, and I'm not going to try and pretend that I know them off the top of my head. I'm sorry.
No problem. With the injections as opposed to the oral tablets, is the side effect profile more favorable in those, or not much difference?
Yeah, no, they are. So the side effects of the injections tend to be more localized. So pain in the penis, bruising, priapism. So they tend to be localized to the penis, whereas the oral medications, you get those systemic side effects, back pain, flushing, headache, that kind of thing. So for men that can get their head around injecting the penis, and that can be a really big barrier for some men, but men that can get their head around that, it can work really, really well. And often men with diabetes, particularly if they're on insulin, they're actually quite used to injecting themselves, so it's not such a big deal.
The vacuum devices, are they generally just through urologists and specialist nurses, or can we access them in a different way in primary care?
The vacuum devices, absolutely. So the easiest way to buy vacuum devices is online. And there are some really reputable stores. There's actually a physiotherapist who's based in Nelson, who has a special interest in erectile dysfunction, and she has a whole range on her website. And she will actually contact the patients by phone and explain it to them and so forth. And I think I said earlier, you can buy them from adult stores, sex shops, that kind of thing. So that tends to be the main place to get them from, rather than urologists, actually.
Oh, thank you. Do you have any comments on the psychological aspects of erectile dysfunction?
Yeah, no, I think that's a really great question, actually. So particularly in younger men, there can be a vicious cycle where you, for whatever reason, maybe you haven't got a good erection. And so then you really worry that next time you won't get a good erection. And it becomes harder to get an erection when you're worried about getting erection, if you know what I mean. So I think particularly in younger men, that's a really uncommon scenario. In older men, particularly that have been in a really stable relationship, marriage for a long time. But I think in younger men, and I see those men coming in their 20s or 30s, and suddenly they're having trouble with erections. And it's really unlikely that they have a significant physiological problem. Often it is that sort of psychological overlay, maybe a bit of drugs and alcohol involved originally, perhaps. But I find the oral tablets like sildenafil can be quite useful just to help to build confidence. So you can give them the sildenafil, and then they have confidence they'll get a good erection. So then eventually they can wean themselves off it, knowing that it is possible.
It's good to know. Are there would you take any different approaches for someone, say, with type 1 diabetes that has erectile dysfunction?
Not really, no. Yeah, it really is just the same. The principles are the same, and the treatment options are the same. Probably the difference with type 1 diabetics is you do often tend to see them a lot younger. I have had type 1 diabetics in their early 30s, unfortunately, that have developed, significant erectile dysfunction. Possibly due to being less compliant in their younger years with their diabetes control, and now they're 30 and they're in a relationship and they're married and they want to have children, and then suddenly it kind of really hits home that erections really are important for lots of reasons. But the management is the same. As a surgeon, always worry a little bit more about infection around the time of surgery, but other than just accepting that there is an increased risk, we'd still offer those men the same treatment options.
With the oral medications, you mentioned a few other things like maxing out the dose and still having that stimulation. Do you have any patient resources that you refer people to go over all of those? Often we really like to give out patient handouts and resources in primary care.
Yeah. We have our own one that we've just developed in our own clinic, which is pretty simple, actually. Fairly simple, but there are quite a few good guides and things available online that just give those nice instructions to men. Try it half a dozen times, not before a fatty meal, half an hour to an hour before sex, those kind of things.
Perfect. Okay. Oh, sorry, we just had about 5 questions coming at once. Some of them are repeats, so someone's asked if treating ED would treat premature ejaculation, but I understand they're probably very different kind of physiologies happening.
Yeah, so premature ejaculation is a really tricky problem to treat. So the thing with premature ejaculation is men have normally got really good erections. There's nothing wrong with their erectile function. The problem is that they don't last very long, so they ejaculate quite early. So treating ED doesn't usually help. If anything helps is a bunch of lifestyle is the wrong word, but behavioral things that can be done, sort of early withdrawal, squeezing the end of the penis. There is some evidence that citalopram, which is the SSRI, can help. It's a tricky problem.
Someone's asked, for men with diabetic neuropathy and ED, that would suggest the diabetes has probably not been very well controlled. Would you take any different approaches, or just as you've outlined?
Yeah, not really. I mean, there really are no other options. As you say, diabetic neuropathy suggests particularly poorly controlled diabetes, and therefore you're likely dealing with little arteries to the penis, which are really, really small and narrow and not functioning very well. They're probably not going to have a great response to those oral PDE5 inhibitors. You imagine if those arteries are pretty much blocked, can't really dilate a blocked artery.
In that situation, would the injectables be more effective?
They would, yeah. And that ladder of options, that, as I sort of described them, as you get higher up the ladder, they also tend to be more effective.
Perfect. Okay, thank you. All right, that kind of wraps up our questions. So thank you again to our speaker, Giovanni, for taking your time to present this evening. Thank you so much to everyone for joining us tonight. So have a lovely rest of your night, everyone.